We're going to cover some points today that I think are really significant. Dr. Crunk is one of the country's leaders in X-ray technology as it pertains to information related to analysis of personal injury protocols. We're going to be discussing concepts of mechanism of injury, objective tools, severity points, lining up diagnoses effectively, long-term ramifications of whiplash injuries, some important value drivers, validating treatment, as well as number one cause of disability worldwide and common mistakes made by doctors across the United States. As we get deeper into this, Dr. Crunk has really done an enormous amount of research. I've been fortunate to speak with him several times. We recently did a seminar in Chicago as well in New Orleans, and he's one of the most dynamic guys in terms of finding information that's going to support the work that we do, and he has a really significant tool in the digitizing space that I think could be valuable for you doctors in managing your cases, and he's really got a unique approach in assisting with that. He does have some strong medical professionals that are available to work on these cases, which gives us some more credible expertise in this arena. And so Dr. Crunk will kind of break down some of these points, and we'll go through explaining how spinal ligament injuries and all the factors, disability worldwide, and all these components. So I'm going to be turning the presentation over to Dr. Crunk, and he will continue with the presentation. So Dr. Crunk, it's all yours.
Okay, great. Dr. DeGaetano, you need to, if you hit the turn me over to make me the main presenter, that way I'll see the screen that allows me to hit the yes, so that they can see my screen.
That should be in your possession now.
Not yet. I'll see it right on my screen as soon as you hit it. You see right where it says make me presenter?
Well, it says here that I just did. So bear with us here. It says panelists.
Yep, when you make me presenter, if you highlight me.
When it says give mouse and keyboard, correct?
Nope, not give mouse and keyboard. Make me the main presenter.
Let's see here.
The cool part about this is after you see it. There'll be a little drop-down menu right there.
All right, there you go, buddy.
There we go. You found it. All right, perfect. First of all, can you see my screen?
Yes, I can.
Great. So first of all, I want to thank you for bringing me on board with your doctors today. I think it's fantastic. Just so you know, the doctors that are listening today, I regularly refer to the Personal Injury Institute. I am not a personal injury consultant. I do not do personal injury consulting. We refer doctors over to the Personal Injury Institute for personal injury consulting. I'm very good with ligament injuries. I'm very good with aspects of things that very knowledgeable in the area of why things need to be documented the way they need to be documented, and how to objectify and how to really simplify these injuries. I do a lot of speaking. I am a DC. I also have a law degree. I do a lot of attorney training. I do a lot of doctor training, DC training, MD training. I've trained insurance defense firms. I've trained insurance adjusters on these various things. Spinal ligament injuries are the #1 cause of pain and disability worldwide. No question about it. They're the most costly thing in the healthcare system today. The profession of chiropractic is in a prime position to take significant advantage of this market. Now, one of the things that I learned a long time ago was when you're talking about injuries and you're talking about spinal injuries and you're talking about the injury medical legal realm, objectivity is key. And one of the in teaching, one of the things I realized was that a lot of doctors did not fully understand the concept of mechanism of injury. So that's what I want to start with this morning. It's a really simple concept. This that you see right here, this injury pattern, is called an injury. It's called a lesion. It's called derangement. It's called a derangement pattern. It's called a wound pattern. And it's caused by a mechanism. And the mechanism is a force delivery system that's capable of causing injury to the human body. Just because you're around the mechanism doesn't mean you're injured. You've been around plenty of dogs, never were injured. However, if you are injured by a dog, there's a very specific lesion pattern that's left behind. And this lesion pattern is very specific for a different mechanism. It's not a dog. This would not be left behind by that sort of mechanism. It would have a different mechanism, which is hot grease. The only reason why I bring these up is so that you can see that there's a difference between the mechanism and the lesion pattern that's left behind. So this obviously is not a dog bite. It's not a burn. Different lesion pattern that's been left behind. Now, if we were to analyze this injury, today, fortunately or unfortunately, there's an overemphasis on the spine, on mechanism science. I'm a huge proponent of injury identification science, and they are different. If I have a gunshot wound patient coming in, I don't care at all about the mechanism. I don't care about how fast the bullet can travel, how many grains of gunpowder there was in the bullet. I'm very interested in the injury pattern that's left behind. Now, I'm also very aware of the fact that just because you're around a gun doesn't mean you're injured, and just because you're injured by a gun doesn't mean it's severe. So if I scratch the bullet or I just provide a scratch to the calf, the patient still has been shot. So doctors, in my experience, need to understand the lesion patterns that are left behind, and they need to be able to differentiate the severity and the location of these injuries, especially injuries to the spine. And that's what I'm good at teaching. So if you have 6 people in an auto collision, per se, it doesn't mean that all 6 are injured identically the same. As a matter of fact, a lot of you doctors have had patients who have come in where 2 were injured and 4 never show up to a doctor's appointment. So just because a mechanism is involved, it doesn't mean that the injury is the same for everybody that's involved in the mechanism. And so oftentimes when I'm in a seminar, I'll say, okay, great, this is a force delivery system. This is a mechanism that's capable of causing injury to the human body. And I'll have doctors close their eyes and say, okay, you know, dog bite. You can see the wound, burn pattern. You can see the wound, gunshot wound. You can see the wound. So if I name those mechanisms, you immediately see the wound pattern. Yet if I say auto collision with your eyes closed, most of the time in my seminars, webinars, or whatnot, you have a black screen in front of you. You don't see the lesions. Now, we as the people who are treating these spinal injuries should see those lesions as clearly as you can see a dog bite, as clearly as you can see a burn, as clearly as you can see a gunshot wound, because these lesion patterns are the #1 cause of pain and disability worldwide. And it's very important, especially in the medical legal area, it's very important that the doctors understand what these lesion patterns are that are left behind. Because again, National Highway Safety and Traffic Administration says this many injuries, this many crashes, 1.546 million, car to car only, not car to truck, not car to bike, car to car. There's this many that are just property damage only, this many are injuries. So we have to have doctors that are capable of determining the severity and degree of injury, and they also have to understand what these lesion patterns are that are left behind so that they can understand proper diagnosis. They can understand proper diagnostic layering. They can understand what the severity and location of the injury are for proper treatment. How does this relate to the guidelines? How does this relate to what the consensus says is the amount of damage? How does this relate to impairment rating? How does this relate to very, very important factors? Dr. DeGaetano is an expert in the area of colossus, where diagnosis is key, impairment is key. I mean, if we're talking impairment to the spine, there's only 3 imageable lesions that are left behind that cause impairment rating, regardless of whether you're in the 5th or the 6th edition. They're a sprain pattern, which is an intersegmental motion problem. They're a disc herniation, which is an MRI. You pick that up with MRI. The sprain pattern is picked up with either the X-ray, flexion extension studies in the CRMA, or a DMX in the CRMA. Official disability guidelines say a DMX is not valuable unless it's digitized. So those are lesion patterns that are left behind. They also happen to be the imageable lesion patterns that cause permanent impairment. So my question is always, doctors, which impairment pattern, which permanent injury do you want to miss? Because like Dr. DeGaetano said in the beginning, is that what condition do you want to miss? Because as far as I'm concerned as an educator, if you miss a permanent impairment and it causes a delay in diagnosis, it always usually causes a delay in treatment. So we know that we have these auto collisions. We know we've seen all this mechanism science that says, look, 13.5 G's of problem here. That means that human head at 10 pounds weighs 135 pounds in a millisecond. That causes severe compressive and shear forces to occur. This right here is what it looks like inside. Now, we can actually look at this. Here is our facet syndrome. Here is our facet tears. Here is our facet ligament injuries. Here are our mechanoreceptor problems with the facets. Here is what is driven, all of the different procedures, the facet blocks, the facet rhizotomies, chiropractic care, chiropractic stabilization care. If we look here, can we cause damage to the disc? Absolutely. Can we cause damage to all the other ligaments that are involved? Absolutely. So in this one model, in this one image, everything that you're going to diagnose as an injury to the spine can be picked up right here. Now, it can also be quantified and imaged. And today, that is absolutely huge, because the more that you actually image and the more that you objectify your results, the better the patient access to any benefits that they may be entitled to, which is key for your people. It's key for your getting your bills paid. This is Mazion. This was early chiropractic, orthopedic, and spinal impairment rating. This is his image of facet syndrome, of facet instability, of facet ligament damage. What is that? That's a translation finding. That's a translation pattern. The back and forth motion would give an indication of how irritated this is and how irritated also the disc is, and it starts to layer on top of your other studies. If I have an area that has significant translation patterns, then I know that I have a problem with the facet, and I can also have a problem with the disc. And so it becomes very, very easy. In chiropractic, best practices for the ICA says, look, you have three main things that you're looking for. Subluxation, which is a misalignment of the vertebra that causes nerve interference. Subluxation patterns can be picked up with intersegmental motion studies. That's a flexion extension study and a CRMA that tells you what the intersegmental motion patterns are. Soft tissue, presence of soft tissue injury, again, that's an intersegmental motion problem. The more intersegmental motion problem that you have, the more severe the indication of the ligament injury is. Make an assessment of spinal instabilities. Any place where you have in the spine abnormal motion and you have a motor, sensory, or pain problem associated with it, you have a spinal instability. All of these things are done in order to develop a proper treatment plan and to drive every single modality that you're going to use, because that's what this is supposed to be utilized for. It's to develop the most appropriate treatment plan and care for your patient. And that's what drives insurers' understanding, insurers' software system. 47 different medical management software systems are driven by your understanding of what the Personal Injury Institute teaches you about diagnosing these conditions. But you can't just put a diagnosis down, because if somebody's looking over your shoulder in the file, they have to have justification for why you use the code in the first place, and you don't ever want to use a code when you don't have justification. So to kind of give you an idea, I learned this a long time ago. I'm going to go pretty quickly because then we're going to get down into some questions, and I'll show you resources that we have. But if you take this patient comes in, they have an auto collision. I know spine-wise what, there's 3 lesions that they could have. They could have a fracture, not highly usual, not in your office. They could have a disc herniation. Usually don't pick that up until later if you do an MRI. They certainly could have a sprain or ligament injury. That's an intersegmental motion study problem. You do flexion extension films. You send that film set out. We do a study on it, and now you know the severity and location of any ligament injury. You do a pain pattern or pain pattern mapping. We know that this is the person's pain. Multiple levels are involved. You do a sensory test, C5 comes up. You do a motor test, C5 comes up. Now you start to look and say, geez, his ability to play golf is significantly reduced, and his ability to work and remain comfortable in the workspace is significantly reduced. Now you have perhaps duties under duress problems, loss of enjoyment of life problems. You take the x-rays, you look at the x-rays. I could put 100 x-rays up with 100 doctors of chiropractic, and they'll all see something different. Same with medical radiologists. You start measuring these things, and all of a sudden now we have a C5 rateable, which is a severe ligament injury to the C5 motion unit that also causes a permanent impairment to that level. I already have a C5 motor problem. I have a C5 sensory problem. I have a spinal subluxation identified. I have a spinal instability identified. And I have the severity and the location of the spinal soft tissue injury identified. Now, if I wanted to, I could also go, if I need to, and I need further information about the disc, where am I going to look for that disc problem? I'm going to look at that disc problem at the area of most ligament injury. That's how easy this becomes. Now I can correlate it to a grading system for justification of my treatment, such as the Croft treatment guidelines. That gives me the severity and location. It gives me the grade. It gives me justification for treatment. And now it's very easy for me to actually go, here are the diagnostic codes, here are the injuries, here's the permanent impairment, here's the duties under duress, here's the loss of enjoyment, here's how much care I used, here was the justification for the care, the patient is not fully recovered, here's justification for future care, and now the patient has a great file worked up. They have access to any benefits that they may be entitled to, which I just threw an arbitrary figure out. And that's how simple it is with what we do. I've been doing this for years and years and years, first as a primary treating doctor, then as a person who delivers these services. So that's what we do with spinal kinetics. That's what we bring to the injury world. For more information, when you sign on with Spinal Kinetics and you start doing services, we have a back office with videos that go over basically the concepts I just showed you. If I have another company called the American Spinal Injury and Impairment Consultants. We have a more extensive ligament injury site. It's $37 a month to become a member of. So, Matt, I'm going to turn it back over to you now for questions. I appreciate you letting me just take the time to give sort of a short overview of what we do.
Yeah, no, and that was fantastic, and I really appreciate the detail on what you were able to describe in a very condensed way. My first question is, how do you find a spine large enough to lean against? Because I'm a little curious how you actually make that work.
That's called Photoshop.
In any case, yeah, well, we've been really fortunate to do some work together. We've spoken in front of a couple hundred attorneys and together and doctors, and the questions that typically come up. And one of the first things, as I was looking at that, maybe if you can give the doctors a little more insight on, let's say the patient had degenerative issues, right, which is not uncommon. They get exposed to this injury. Describe how Spinal Kinetics would handle that, and then what actually Spinal Kinetics would actually do in reference to the reporting. Because I think some of the doctors understand a little bit about what you do, but explain what type of report is delivered with the X-ray technology, digitizing, and then obviously pre-existing disease versus non or asymptomatic pre-existing disease.
Oh, I'll tell you what, the one thing that you bring up, and you bring up a couple of really great points. In my experience, I've learned that I do a whole program on pre-existing conditions are so incredibly easy to handle. But let's just take pre-existing condition of degenerative disc disease. I'll give you a basic overview of how an intersegmental motion test takes you right out of the pre-existing condition issue. Let's say that on this spine, and I could pull up a spine, I don't have time to do it today, but I could pull up a spine that shows I've got bad, moderate to severe degenerative disc disease at 5 and 6 and 6 and 7. Now, those joints should be stiffer by nature, correct?
Yes.
Okay. Now, if they're stiffer by nature, and I'm in an auto collision that causes shear force and compressive force and is going to shear the ligaments, where we usually will see more shear damage is up above the degenerative condition. So let's say that I have this moderate, these really bad degenerative disc problems. If you start getting into intersegmental motion studies for alteration, motion, segment integrity, you're going to see that those are commonly above those sites where there is no pre-existing condition, and that is the lesion that's consistent with the damage pattern. So now, when people think of degenerative disc disease, they think of, since it's in the cervical spine, it's all affected. That'd be like saying, well, since it's in the body, since it's in the neck, it also affects the lumbar spine, and I'm going to use a cervical pre-existing condition to determine why I have lumbar pain. Nobody would go with that. So when people have degenerative disc disease, say in the lower discs, and yet they have severe ligament injury in the motion unit that has no degenerative disc disease, you don't have a pre-existing condition problem anymore. So it's incredibly useful for pre-existing conditions. Now I could go into the difference also of a dormant and active pre-existing condition and what the law says about pre-existing conditions. I could go into the actual law of the basic law, principle law is you have to take the person as they are. So if I do a presentation for case law on pre-existing conditions, and if any doctor who's doing these types of injuries looked at what the common case law sightings are for pre-existing conditions, you'd never have a problem with pre-existing conditions again. So it's incredible for pre-existing conditions. It's incredible but it comes with, like I will say that to a lot of doctors, and they still will be kind of, well, I don't understand what he means. How does that work? And it's like anything else. You have to start to work with understanding the ligament injuries themselves, and as you go, your breadth of understanding just significantly improves. So it becomes very easy for pre-existing conditions. Now, I don't remember, what was the other factor you said, Matt?
Well, pre-existing symptomatic versus pre-existing asymptomatic. So you have a patient comes in, the patient was under care, right? You often see this with a chiropractor. Patient was under care, was receiving, treatment 2 or 3 times a week. The patient comes in on Monday, tells the doctor, yes, by the way, I was in a car crash on, Saturday night. So now the doctor has to separate those factors. But you handled the degenerative component on that. Maybe kind of describe if there is this differential, which often occurs, where there was an old injury, new injury, and then maybe the apportionment side of that. Do you guys help with that at Spinal Kinetics?
No, because just like let's say that you send in 2 sets of X-rays for a read, or 2 sets of MRI. A patient goes in for an MRI on one case and then goes in for an MRI on the other case. There's a standard read, and then the treating doctor has to take that information and differentiate and use it. On pre-existing conditions, the worst case scenario, so let's say you're doing a 2-time-a-week, 3-time-a-week patient, that of course is the worst case scenario. Let's say that you're doing a Blue Cross Blue Shield and they come in with neck pain, and you say, hey, you need to be on a 3-time-a-week treatment plan. The first thing that a guy like me, a doctor like me, says is, what are you treating?
Okay.
What is it that's causing the problem? Because you have to be able to identify what the cause is. Let's say you say the cause is a C5 and C6 problem. and now they're in an auto accident and they have a severe C2, C3 ligament injury. You got different, now you have different factors. Now I realize it gets complicated, or it has the appearance of being complicated, but it only has the appearance of being complicated because a lot of doctors don't understand how to differentiate the conditions they're treating. And if the condition is completely different from what you originally started to treat with, apportionment is a lot easier. Now, if it's not, let's say it's the exact same issue. You say, I have a C5, C6 problem that I'm treating that's causing the person to have an arm condition, that it's causing them to have pain running down their arm. I've started them on a 3-time-a-week schedule. And by the way, the scenario I'm saying right now, in the last 10 years, we find this scenario maybe 0.5% of 0.5% of 0.5% of 1%. Okay, normal pre-existing conditions are they're so broad, they're broadly different that they're so easy to differentiate. It's unreal. But let's just take that really rare case. Well, then you have to take a look and use your tools. What tool did you use to assess? When I said if a doctor took an X-ray, Matt, the ICA guidelines say do a subluxation assessment, a soft tissue injury assessment, and a spinal instability assessment. That's what our best practices say that a doctor of chiropractic is supposed to be doing. So if I have what was your subluxation assessment, what was your soft tissue injury assessment, and what was your spinal instability assessment when you first started your 3-time-a-week program, and now I see, well, what was your subluxation assessment, what was your soft tissue injury assessment, and what was your spinal instability assessment, all of which are based on motion, and I see mild excessive motion on the first and severe excessive motion on the second. Again, it makes it much easier to differentiate the pre-existing condition and how to apportion. And apportionment, apportionment can get down to as easy as it can be arbitrary when it gets in the hardest stages. And as long as you have great rationale for how you're apportioning in the most difficult situations, that becomes what your apportionment was. So it's like I said, it's pretty easy. But it'd be easier if I actually did a program on that and I showed you pre-existing degenerative changes and showed you real live case studies, because we get them all the time.
No, I think that would be a good follow-up opportunity for us. And so,
sure.
Let me, for the doctors, jump on. If you have questions, please look at your sidebar. There's some options to fill out some questions there. I got a question here from Dr. Hitchcock. He has a question pertaining to when is the best time to perform DMX radiographs. So maybe help understand that DMX obviously is one option, and not all cities have them available, and that's one of the challenges I typically see is that not every city has availability for DMX. But in your estimation, when is there a better time? Is it early? Is it middle? Is it late? What is your understanding as it pertains to the best time to order DMX?
Well, you have to go by your national guidelines. National guidelines will say 6 to 8 weeks. You have to understand DMX is not a primary imaging tool. So I've been a X-ray CRMA advocate forever because X-ray is your primary imaging tool. So if I have an X-ray that shows that I have severe ligament damage, I have alteration, motion, segment integrity, I have my CRMA, you have to decide what your rationale is for using a secondary imaging study to further gain clinical information that you don't have from the primary imaging study. Now, your secondary imaging examples, or your secondary imaging things that you can use are obviously CT if you think there's a fracture, or you have MRI if you think there's a disc. If you're feeling like your ligament study is devoid, then you would go to the DMX. And the DMX, some of the advantages of DMX are the fact, and we love DMX, don't get me wrong, I mean, we digitize DMX. The official disability guidelines say that the DMX is really not of any value without a digitization study, and doctors have to be careful because there are softwares out there right now that are digitizing DMX, but they're not using AMA methodology, and some doctors are now reporting AMA impairments with non-AMA methodology being used with the systems that they're using for mensuration. So you got to be careful with this stuff a little bit. You have to understand what you're doing with it because you are in a medical legal situation often. So, you know, as far as DMX, it's your choice. Usually it's done 6 weeks after minimum, and then you have to decide what is the additional diagnostic value. What are you looking for in addition to what you've already done? And then whatever that information is that you're looking for, how does it drive what you're going to do with the patient?
All right, well, here's a follow-up to this. So the next question Dr. Hitchcock shot again was about CRMA. When is the best time to use this as it pertains to the plain films that were utilized or digital films that were utilized in that doctor's office? What is your approach there? What do you recommend?
Well, that's a great question because when you have the plain, if you shot the plain films, you use the CRMA right away. So if you shot your flexion extension studies, there's concerns sometimes that, hey, spasm and inflammation will retard intersegmental motion, and it can. It's rare, but it can. So let's say that your patient can't flex or can't extend. Well, then you can't really do a good stress study. You may at that time decide in your handling of the patient that you're going to wait for 1 month, your re-exam period. You're going to put in your documentation, look, patients in apparent pain and spasm cannot do proper flexion extension. No way for me to do an intersegmental motion study at this point. We'll do care to improve the range of motion of the cervical spine so that flexion extension can properly be done. At that point, we'll do flexion extension studies and do a ligament assessment at that point. So if you feel like you have a ligament injury and you have films that are going to show that ligament injury, you're going to do a CRMA right at that point. Does that make sense?
That's perfect because, you know, obviously now it also gives you the opportunity to determine the validity of the care that you're delivering, right? So that now sets the bar. And maybe take the next question there because I know a lot of doctors have this this question that is, well, if there is ligament damage, then how is it justified to do manipulation in the area where there is ligament damage?
I am so glad that you brought that question up. Unfortunately, for the profession of chiropractic today, the profession of physical therapy is catching up very, very rapidly. So a doctorate of physical therapy today in their textbooks are taught that the area of most severe ligament injury, now you can't take this out to a spine that's not capable of any kind of an adjustment. So there are gradients of instability. And there can be a point of instability where no manual anything should be done. That's not what I'm talking about. I'm talking about instabilities that are within a manageable level that can be adjusted. So in the doctorate of physical therapy programs, they're explaining to their doctorate students that the area of most injury, most ligament injury, is the most important to adjust. And to get to that point as quickly as you can. Now in chiropractic, if I go out to the ICA best practices, they will say that this spinal instability, this causes a spinal subluxation, needs to be adjusted as soon as possible to reduce the spinal instability. Now, doctors of chiropractic are concerned. There are 17 subluxation patterns that were presented to Medicare, and hypomobility is only one of them. If we stay with the hypomobility model, I'm going to tell you that studies and services like spinal kinetics will say that chiropractic is no longer needed. If you look at the original subluxation patterns, instability, hypermotion, aberrant motion of the spinal motion unit was one of the most important subluxations to treat. Now, how do we treat it? How do our adjustments affect it? When a ligament is damaged and a spine is misaligned, we know that type 1 and type 2 mechanoreceptors shut down. We know, and type 1 and type 2 are embedded in the ligaments, type 3 is embedded in the muscle, type 4 are the nociceptors or the pain receptors. So if type 1 and type 2 on all misalignment patterns, the input goes down, type 4 goes up, and pain patterns go up. Anytime that you adjust the spine, you are improving the type 1 and type 2 mechanoreceptors to regain neuromuscular control. You have to understand that the muscle sequencing patterns, the stability of the spine is in the muscles, not in the ligaments. And it's in the ability of the body to properly activate proper muscle sequencing patterns for the need of the spine at that point. There's muscle sequencing and coactivation patterns. The timing of when to turn one on and when to turn another off is done with the pressure in the mechanoreceptors. So the beauty of spinal adjusting is that it causes an instability to become stable. That's what I could take from just a mechanoreceptor point of view, describe every condition in the body that benefits from spinal adjusting. And now I can elevate the science, our science, with real science, not with, okay, let's just bring the patient in, let's roll them right, let's roll them left, let's roll their neck right, let's roll them left. 80% of the time, good things happen. That's all I need to know. That's never going to elevate the science of chiropractic. And if we don't elevate the science, we don't get the market. And right now, physical therapy is elevated. They're taking our adjusting science and they're elevating it. And it's a beautiful thing because basically they're saying, hey, just read this and you'll understand exactly what you've been doing for the last 115 years. So it's very, very easy to understand once you understand the ligaments and mechanoreceptors and what a spinal adjustment does to that. Again, it drives your whole treatment understanding.
There's another question right here, Dr. Jones. He says, how do I help law firms understand this technology, and how does it tie into marketing?
Okay, perfect. Those are great questions. I always answer the question the same. How you help an attorney to understand it is by first and foremost you completely understanding it. If you completely understand chiropractic, you don't need to be told how to market it to attorneys. You just go out, you exude it. Your confidence in it, your ability to explain it, your ability to explain how it works for this and that, and all of these various circumstances goes through the roof. If you watch me go in and talk with attorneys, it's very, very simple. Now, when I say it's simple, we all know that attorneys don't understand the conditions that they're representing, generally, and they very often do not even understand what the insurers need. So if you say colossus to an attorney, they don't understand what that is. It took me 2 years to figure out if I said spinal ligament injury, they didn't know what a ligament was. So you have to start on a gradient that's acceptable for wherever they are. And at first, it can be just all we're very, very good at doing is objectifying the injury. Objectifying means that you take out the subjectivity of the injury and you now have verifiable injuries and verifiable consensus as to what it means. In my personal experience, that didn't really start to take off until I had attorneys deposing me. And once they started deposing me, doctors, when you're deposed, there's a thing that happens in the room, you're deposed, and then there's a thing that happens in the hall. If your deposition goes excessively well, the thing that happens in the hall is that your attorney wins in the negotiations in the hall. If you are very difficult in deposition, you're all over the place, you don't explain things well, it's difficult to understand. The hall conference goes very poorly for your attorney. And that's the simplicity a lot of times of these medical legal situations, is how clearly can you explain and how much consensus. I mean, when I'm sitting down explaining things, I don't ever use my own opinion anymore. There's too much consensus on everything I'm saying. I just put out the consensus. You want to argue? Argue with the AMA. You want to argue? Argue with the National Peer-Reviewed Guidelines. You want to argue? Argue with what the Medscape site says about whiplash or whiplash injuries. You want to argue about chronic pain? Go to what the insurance industry site, the Reed Group for Disability Guidelines, states about chronic ligament injuries. These are the sites that are training the insurance adjusters as to what these conditions mean, and in those guidelines, they'll state very clearly, look, the magnitude of impact of a injury does not correlate to the magnitude of injury. So I just use consensus and then present the consensus, and if they want to argue, they have to argue with the Reed Group, the top group in the world for insurance guidelines. So there's there's just so much consensus, it makes it so easy.
Well, Jeff, you did an outstanding job presenting some really quality content, and one of the things that you and I have had the opportunity to speak together on is the unlayering of this information and delivering it to those that we can work with. Invariably, as clinicians, a lot of law firms that we may work with don't understand injury, and that's the scariest part in this arena, is that they're delivering information about a demand but not really understanding all the components as well as they need to, and that's where obviously the education, as you described, is so key for them to be successful at making them aware, and then obviously growing this area of the practice in a very successful way. Because you can certainly grow it where it is not successful, because there are reductions that are coming because the injuries are not properly identified. And so if they wanted to find you, I guess maybe in a formal way, and then obviously maybe informal, they can email you with the questions. Is this where they need to go, is spinalkinetics.com?
Yep, and if they would just call the 715-833-8533 number. I'm available, doctors. I work 7 days a week like you do. This is my passion. I'm at 10 o'clock on Sunday nights. You can call me and talk to me about spinal ligament injuries. Monday morning, if you call me at 3 a.m., I may not, pretty sound sleeper. But if you have questions, please call us. If you want to start using us, please go out to our website, contact our number. We'll get you started right away with a referral kit, and also with a back door to our website that has training videos that explains exactly what we do, why we do it, how you use it, how you read the report, things like pre-existing condition. Those types of materials come up, and it makes it, for me, it just makes it a lot easier. I started using X-ray digitization with Spinal Logic Diagnostics in 1995, and from 95 to 2004, I don't believe any patient that was injured, I sent them off. So I have a lot of experience with it, both as a practitioner using it and as a person who's delivered it and built the systems that delivers it. So by all means, use me, use us. Matt, I so appreciate the amount of time that you gave me. I know we'll do more in the future. I love it when you and I get together on stage. You're one of my favorite people that I like to speak with, because you tie in then the colossus and the attorney information and making it easier for them to connect with these folks to be able to expand their practices. So I really appreciate your time.
Well, thank you for joining us. And yes, there will be some more sessions. I don't know that we were able to cover all those points, but we'll definitely circle back around on some upcoming sessions. And any doctors that have any questions about the Institute, please email me directly. I do have an informal side where we just answer questions for you. If you want to go into more detail, speak with me in person. I do a practice consultation to kind of see where you are, what the nature of your practice is, and see how we can assist you in expanding in different directions where you can work with our medical professionals or anybody on the teams that you may need to work with in our space. So that's definitely something that we will make available to you as well. But in any case, we'll send out an email for thank you for attending, and be on the lookout for one of the upcoming sessions. We still are in the process of our breakthrough DNA blueprint and going through our profit activators. There'll be another profit activator or so coming out in the next week or so. But in any case, everybody, thank you for your time, and we look forward to seeing you in the future. Thank you.